Great to be here with you, Dr. Levy. You know, we have a lot of different screening options for breast cancer, and from my world of prostate cancer, I keep thinking about the different ways you can screen for cancer. What patients do you think, particularly in the context of breast cancer, benefit most from supplemental screening? You know, obviously everybody gets mammography, but there's a plethora of other tests that you can use to add on to mammo. What ones are helpful, you think, and how do you typically, what's the algorithm you use?
Yeah, so there's two questions there. One is which patients should have supplemental screening, and I think we have basically two groups. One is the group of high-risk women. So whichever screening tool you use, a predictive model, if they have a high risk, family history, personal history, genetic mutation, those are patients that we have seen need additional screening beyond mammography. The second group, and the group that's much more difficult, I think, to manage, is the group of women for whom mammography is not so sensitive. And that's the group of women with dense breasts. And I, in my mind, really separate the women with heterogeneously dense breasts versus that small group, 7 to 8%, who have extremely dense breasts. Mammography is not very useful in that patient population. It misses a lot of things. And so those are the women for whom we should at least think about what else we might do to provide them with adequate breast cancer screening.
Now, I know we have AI permeating everywhere into healthcare. Has AI made inroads into breast cancer screening too? I know we use some AI tools and routinely have been for a long time in overreading mammograms, for example, but I don't know if it's gone beyond that. Has it been helpful?
Not so much, and I think the reason is the limitation of imaging itself, right? So when you're looking at black and white, when you see a lot of white, being able to distinguish a tumor within a lot of white, even with machine learning and AI, I think is really problematic. So I think it's the limitation of the use of imaging as our screening tool.
So that leads us to the question, you know, what can we do about improving breast cancer early detection without, consequentially increasing the number of interventions in these people? Is there a way to customize it or think about it better? Because we can't afford it, and the health system can't afford it. The morbidity adds up, so.
Yeah, so my philosophy is that we've been approaching breast cancer screening the wrong way. Like, to think about imaging as the first way, the first screen, has never made great sense to me, right? We're looking for a lesion, a mass, something, when what we really care about is the biology. Like, what's happening in the breast, and is it something that will become life-threatening to this patient, or is it something that will sit there? My analogy to patients is it a freckle or is it a melanoma?
Yeah.
Right? And imaging is not the best way for us to make that distinction. It's just the only thing we have right now. But what's exciting about what's happening in the world is there's so much opportunity with the technology that we have now to look at genomics, proteomics, all kinds of characteristics of the body's response to what's happening.
You know, I've been dealing with prostate cancer for a long time, where we mostly led with the PSA, the blood test screening, but just to then incorporate imaging as a second test or supplementary test took us a long time, almost 40 years now, before we could really change our minds around with this. And so I think it's curious to me, observing from the outside, how breast always led with imaging first, and nobody thought of switching it the other way around.
Yeah, we never had markers for what was biologically active in the breast. For many reasons, I think, but we just didn't have PSA equivalent in the breast. There are now research things going on in proteomics, in, what do they call it, immunomics? I mean, they're all
metabolomics, every kinds of omics.
All kinds of omics. You know, I don't think that the genomics helped us as much as we would have wished. It's great to be able to look at the high-risk genetic mutations that are familial. That's about 10% of breast cancer, but there's the other 90%.
It's really a great time to be in medicine in many ways, but to your point, we need to use that to really help our patients and drive down costs and make it more comfortable.
And we need to be curious and humble.
That's right.
Right?
That's right.
Two things.
Yeah.
We need to recognize that what we're doing now is not ideal, and we need to be curious about what might be better.
Yeah.
And then we have to have the conviction to pursue those things.
That's right.
In the interest of what's best for our patients at a population level and at an individual level, both.
Now, speaking of populations, I mean, you manage a vast network of patients who are, across the United States. And how do you appropriately reassure patients? It must be a real challenge for you because you want to warn them to be vigilant and concerned and continue screening. You don't want them to give it up, but at the same time, you don't want them to be kind of losing their mind every year when something shows up abnormal.
You know, I really trust my patients, and I try to help my patients trust themselves. I do believe that your body tells you when something's not right, and that women should pay attention to that. So we've given up the monthly breast cancer screening with the shower card and the thing because it picked up a whole lot of things that were nothing. And we've given up even the clinical breast exam because the data shows that that doesn't pick up asymptomatic cancers either. Mm-hmm. And it does pick up a whole lot of cysts and things that are nothing. So the first thing is to tell women to trust themselves, and when they have a gut sense that something's not right, to pursue that. The second thing is to share with them honestly that these screening tests are not perfect, and that if she feels something different, it deserves a biopsy. Like feeling something different that's persistent. I don't care what the mammogram shows. 10% of cancers don't show up on any imaging at all, even MRI. So if she feels something different, we're going to pursue that and make sure that we know what it is.
Now, what clinical scenarios create the greatest uncertainty in your mind? You know, and forget the reassurance, but what really, like you said, triggers your anxiety a little bit and leads you to think differently?
So it would be the patient that has the extremely dense breasts, because I can't have confidence that her screening mammogram gives me much information at all. And then the question is, so what do I do from there? There are no consistent guidelines. So ACOG would say there's no data to support additional imaging, whether it be ultrasound or MRI. The Society of Breast Surgeons, on the other hand, would say these patients need ultrasound and maybe MRI. And the problem is that these are all imagings, right? They're all imaging studies. And so they have higher sensitivity, will pick up more things at a cost of significant reduction in specificity. So the more you do, the more likely she's going to need a biopsy that's going to be nothing. That raises anxiety. And even in the randomized clinical trial of MRI as a subsequent screener, we currently don't have any data to say that the outcomes are any better. I wish there were as much curiosity for breast cancer as there has been for prostate.
That's quite surprising, you know, but given the amount of attention that breast cancer demands, particularly because it affects young women and
it does.
Younger people, and the age is kind of going even lower now with the screening starting at sometimes at age 40 with demonstrated high-risk groups and high-risk clinics that we run. I get this question all the time in our high-risk clinics. There are women who are getting, you know, some sort of imaging every 6 months or something. It's very tension-provoking, and we are not sure what to do with these.
We are not sure what to do, and I think the answer, long-term, will be to change our procedures. It really is to change the paradigm and to move it towards the prostate cancer. That makes so much more sense, right? Start with the biology, and when the biology points you to something that might be significant, then you follow with imaging to see if there's something there. But that's a huge mind shift.
Yeah, it is. That is a mind shift. But it's very heartening to say, at least to learn from you, that maybe something that the urologists were doing were actually good things that other people can actually emulate. But yeah, no. Well, because we've learned a lot from the breast cancer world, right? I mean, they're very kindred cancers, if you will.
Yes.
They're both hormone driven, and so there's a lot to learn from each other. So we look to breast all the time when we like to look at the next steps. And for example, MRI came out of all the breasts. Even the grading system, the biorads and stuff, we have the similar thing for prostate. So it's very interesting.
Well, my hope is that we come closer and closer together, and that with curiosity and humility, we can get to a place with breast cancer screening much more aligned to what we do with prostate. Now that we have the technologies and they're commercially available, they're available to use, and we have the machine power of machine learning to be able to figure this out, that we can change that paradigm, that we can move towards a more biologically based screening mechanism.
Yeah, no, I totally agree with you. I think the time is ripe. And I think with people like you and others who really are willing to think differently, it is going to happen. And I think the women deserve better and better answers than what they've been getting so far.
They certainly do.
Yeah.
To learn more, visit certitudetest.com.